Hello, everybody. What is the importance of OCT in your daily routine corneal tomography? Well, in my mind, OCT is better. And this is not just due to one factor, 2, 3, or 4, but actually I can name more than 5 reasons why OCT performs better and does things that ShineFlow cannot. Now, they say beauty is skin deep, and OCT shines the deeper the structures. And typically in post-cross-linking, we see sometimes corneal haze that can be mild, moderate, or severe. And compared to ShineFlow, OCT does a better representation of cornea thickness. As we see here, the more the haze, the more the underestimation of cornea thickness by the ShineFlow. And that's a study that we have shown in AJO comparing ultrasound, pachymetry, ShineFlow pachymetry, and OCT. Of course, OCT does a better posterior float representation. Again, this is more illustrated when we have any opacity in the cornea. And when we see this opacity on the slit lamp, anterior stromal opacity, the posterior float shows also a coin-like protrusion right smack underneath that opacity, compared with OCT, where we don't have any of that, no artifact here whatsoever. Again, Theo Seiler has shown that long time ago and have shown that ShineFlow does a lot of scattering, especially with corneal haze. OCT does a better posterior curvature evaluation, and that's very important when we're trying to do ray tracing to determine total corneal power, typically post-refractive surgery, post-radial keratotomy, and other kind of surgeries or irregular corneas. Of course, better posterior corneal curvature is important to determine whether the patient has early keratoconus or not. In this evaluation of the best fit sphere, we see a temporal elevation of the best fit sphere. And that can be due to true elevation, and that can represent early keratoconus, or it can be due to high angle alpha. So in that case, when we look at the posterior curvature, it's a perfectly nice bow tie shaped astigmatism. And we can deduce that this artifacts we see, or this elevation we see, is due to a large angle alpha. Now, sometimes we're busy scrutinizing the deep, but we need also to look at the top and see where the OCT also shines, and that's in evaluating the corneal surface, namely the epithelium. Looking at this cornea, one day off contact lenses, and you can see how the epithelium is all mugged up. We have contact lens warpage, we have thickening, as you see, and then the periphery, we have flattening. And then wait 2 weeks off, same patient, and look at the epithelium, and we see a very smooth epithelium here. And that's also very important when evaluating refractive patients. Sometimes 1 week or 2 weeks are not enough of contact lenses. And doing a corneal tomography, looking at the epithelium at the same time, can give us an idea whether this patient is ready or not. Now, also epithelial toricity is important. As we see here, this is a cornea with astigmatism. And as you see, the epithelium is pretty smooth and overall homogeneous. This is the other eye with a little bit more astigmatism. And as you see here, we have a lot of epithelial thickening alongside this astigmatism. And that's very important whether you're planning a PRK, a trans-PRK, or a femtoLASIK procedure. So again, looking at the epithelium is vital here. Now, how about the relation between epithelium and posterior curvature? You can do 2 things at the same time and benefit from OCT here. Example, looking at this hexa map or 6 maps. I like the 6 maps because it can show me the Placido and the raw image, the infrared image, just to make sure that we have good centration, the eyelids are not too much obstructing. Looking at the epithelium on the left lower side, look at the anterior tangential curvature, posterior tangential curvature, cornea thickness, pachymetry right in here, and the posterior elevation, BFS, best fit sphere. So looking at the anterior curvature, one would notice that we have a displaced apex or inferior steepening on this cornea. However, looking at the posterior curvature, we see a perfectly nice bow tie. And then if you think about the anterior corneal curvature and the posterior with a relationship of about 7 times, we can look at a scale of about 1.5 diopter as an absolute scale on the anterior curvature, and we have a representation of almost the same scale of about 0.2 to 0.3 diopter on the posterior curvature. So if we look at these two scales together, the same color changes in the anterior surface should mirror the changes on the posterior curvature. And as you see here, of course, posterior curvature is not affected by the epithelium and is detected by OCT. So it's a much better representation than any shine plug technology, especially with haze. And as you see here, you have a nice posterior curvature, but you have a very irregular and asymmetrical anterior curvature. Now, again, you look at the epithelium now, and you can see that you have thickening inferiorly while you have thinning superiorly. And that can account for the steepening inferiorly in the anterior corneal curvature. So again, here looking at all these three maps would give us a better representation of the true patient's condition or corneal condition. This is another example with inferior steepening. And again, we have a lot of thickening inferiorly on the epithelial map, a lot of contact lens warpage, while the posterior curvature looks pretty good as well. So looking at the posterior curvature, the epithelium, and the corneal curvature, anterior corneal curvature, can give us an idea, again, of the status of the cornea. Now, how about post-refractive surgery? Again, looking at the Hexa map, one can deduce that this patient has myopic treatment because of the flat oblate cornea we have now. But again, looking at the OCT section of the corneal tomography would let us see the corneal flap, the LASIK flap, and we can even measure it right off the bat. So this gives us, again, a full representation of the patient's status and the previous surgeries he's done or she's done. Again, looking at the epithelium, we can see that there is thickening of the epithelium centrally as opposed to a little bit thinner epithelium peripherally. And this is, again, gives us an idea the patient has had some kind of myopic ablative procedure. Now, interesting to see here a patient with minus 3.5 diopter preoperatively, looking at the epithelial map, and we can see that there is a kind of a homogeneous epithelial profile. Now, this very same patients undergoing trans-PRK can have a very thin epithelial layer centrally 1 month post-op, and that can explain the hyperopic shift we see very often post-PRK, typically when we follow patients. And then again, at about roughly 3 months, that epithelium has thickened tremendously, but still has room to grow and thicken even further, because as we know with myopic treatment, the central cornea would even thicken much more than the periphery. So he would still have some room for improvement and for thickening. And this explains why the hyperopic shift gets much better a few months down the line and ultimately to reach our final goal. So this sometimes explains whether our hyperopic shift is a true hyperopic shift or is it a pseudo hyperopic shift from the epithelial remodeling. Again, Dan Reinstein has very elegantly shown us how epithelial remodeling can be very aggressive the smaller the optical zone. Like in this case, a very small injury to the stroma, the epithelium would rush and fill out that crater right off the bat. While Paulo Vinciguerra has stressed the importance of the curvature gradients. So combining both principles, looking at large optical zones would give us the best in terms of epithelial remodeling, the least epithelial remodeling, and the best in terms of final refractive outcome. Again, thinking along the same line, this is a myopic patient where the treatment in the center yielded a 62 micron of epithelial thickening, while at the periphery, about 50 to 52. That's a 3 diopter of myopic treatment. Now look at this 3 diopter hyperopic treatment. And as you see here, the periphery is about 73, the center is about 43. The difference is about almost 30 microns as opposed to 10 microns or 12 microns in the myopic treatment with the same diopters of treatment. And this tells us that hyperopia can vary a lot. Of course, I can show you other examples where with 3 diopters of treatment, the difference between center to periphery was only 10 to 12 to 13. So this fluctuation, this scatter, can be responsible sometimes on the large spherical equivalent scatter we see post-hyperopic treatments, as opposed to the very tight scatter we have in the myopic treatment. And again, the larger the optical zone, the better. But this tells us that if you're not looking at the epithelium, we're not doing refractive surgery, as Dan Reinstein's put it again. And that's why looking at a tomography at the epithelium, along other important measurements that the OCT tomography gives us, is vital as refractive surgeons. Now, again, looking at post-cross-linking patients, we can notice that using OCT tomography, we can notice the demarcation line. We can check at the same time if there are haze areas in the cornea. We can estimate the haze, and we can look for any corneal ring segments, their depth, how deep they're placed, and where. So everything can be computed and directly looked at right even before looking at the patient. Now, sometimes there are some information that are not given, but we can deduce. Like in that case, if a patient comes to you with this demarcation line and you're not sure whether that patient had PTK with cross-linking, PRK with cross-linking, or cross-linking alone. So irregular tomography won't be able to tell you, but OCT, especially high definition OCT, can. And looking here at that OCT, you can tell that Bowman's layer is really bilaminar. And if you have a bilaminar Bowman's layer, as you can tell here, the Bowman's layer is intact. While if you have one line, that's not a Bowman's layer, that's a basement membrane, and that patient would have had a PTK or PRK. So this patient did not have a surface ablation. This patient had only cross-linking. And that's, again, a tip you can get from OCT. So I'm going to show you a case, an interesting case, and for the sake of time, it's just going to limit it to one case. This is a patient with day 11 after LASIK flap replacement post-trauma. So that patient had a rubber band injury to her eye. She's done the LASIK more than 10 years in an outside clinic. She came back with a displaced flap and a torn flap in the middle. We repositioned the flap. The torn flap was left to heal by primary healing. No suture was put at that time. Patient did very well. Day 11, she came back to me telling me that her vision was worse, and that's what we see. Epithelial ingrowth smack in the center of vision. And of course, this slit lamp can tell us much. It looks like these epithelial ingrowth are in the interface. And of course, as a knee-jerk reflex, one would just take it to the operating room, lift the flap, irrigate, put suture, and maybe even glue sometimes, and follow up patients. But again, couldn't get really the depth on epithelium, and I felt not really sure. And of course, having OCT tomography, within your OCT imaging was great, because this is what we see with OCT tomography. This is an anisomorphic image, and as you see here, this is the flap edge. You can see it really good when the image is kind of compressed. And then the haze seems to be on top of that flap, probably in the middle of the stroma. Now, looking at the regular OCT image, and again, you can see that the epithelial ingrowth is on top of that interface in the stroma, and you can follow it all through, even from the periphery. So that's pretty interesting. The interface looks pretty good. And actually what we did is not relifting the flap. What I did is actually performing a PTK treatment, debriding everything using PTK, putting mitomycin C, because mitomycin C can sink all the way down. So whatever residual, especially at the periphery, because the center was pretty much shallow, but the periphery was a bit deep. But putting it on the periphery, because this flap is meniscal and was done probably using a keratome in an outside clinic. So the mitomycin C would take care of whatever deeper cells available, but the central ones would be taken care of using the PTK. And that's the patient 1 month and 3 months after. You don't see any trace of the epithelial ingrowth neither centrally nor at the periphery. And again, using OCT, we could tell that, and it saved us an unnecessary trip to the operating room and that's really vital in this case. Another important thing is that OCT gives you a great representation of posterior curvature, hence it can give you great posterior curvature aberrations. Why is this important? Because then we can have the total corneal aberration. We know that anterior stromal cornea is negated by posterior stromal cornea. So if we can get the total corneal coma, there would be better representation of the treatment, that would shave much less tissue during treatment, and it will hopefully give us a much more accurate result. And that's why I think total corneal wavefront will be our next frontier in customized laser ablation, thanks to OCT technology embedded in the corneal imaging. And again, garbage in, garbage out. Shine fix is great, but in these patients where most likely you have scar and haze, we want OCT technology to give us a better representation of the corneal curvature and the corneal aberrations. So as a final conclusion, I do think definitely that OCT tomography does better, and I hope I showed you examples where really OCT is great in your regular routine daily practice. And again, it adds a new dimension to tomography. We always think of topography, the topography being the surface, tomography being the posterior surface, but actually with this, it's huge difference. It's everything which is in between, everything else, like determining things that you would not have be able to determine with a regular shine field tomography. But most importantly, finally, you as the physician need to make sense of all these measurements. It's great to be able to have a great camera, but the more important factor here is the physician to make sense of all these measurements and all this data available to you. Thank you.